I was invited by the Lymphoma Association to give a talk about the future of haematopathology. Actually, I'm a haematopathologist, not a hematology. I deal with diagnoses, and not only from the morphological point of view, but also from the molecular point of view. And I had to explain what the new developments will be in the next 5 years. It's quite varied among different laboratories, and also it's quite different from state to state. So in the UK the organization is different from other places all over Europe, and currently most laboratories do a histopathological diagnosis based on morphology and immunohistochemistry. Some laboratories might add some molecular biology tests, but of course very few laboratories can provide very advanced techniques like next generation sequencing. So the situation is quite different from laboratory to laboratory. There might be problems in standardization because of course larger centers have more opportunities to come to the correct diagnosis thanks to the newer technologies. So it would make just sense to try and centralize laboratories for more advanced techniques so that patients can access these newer technologies without the regional differences, so to say. First, I think that classical histopathology is there to stay because it provides anyway a lot of information. Of course, we will see a great increase in molecular testing. This poses, as you said, a problem for standardization because they have to be accurately validated. And we will see a decrease in cost for molecular tests, so this will be more and more applied. We expect to have mutations in the DNA which are affecting not only the diagnosis but also the prognosis and the prediction of response to therapy. All this mutation could be detected in tissues and so might be part of the diagnostic laboratory for haematopathology. For sure, mutation detection will become more common for patient stratification. For patient diagnosis, this is not so the case because very few lymphoma entities have very specific mutation. I can think only of lymphoplasmacytic lymphoma, which is a MYD88 mutation, but other lymphomas have a very wide spectrum of mutations, and so I think that mutation detection will be mostly useful for patient stratification and for prediction of response to therapy. Also, I have a particular interest in RNA sequencing. I think it might have a future in the laboratory because it can predict a lot, it can provide a lot of information. It can provide gene signatures, mutation signatures for genes that are expressed, and also specifically in lymphoma we can use this for clonality detection. So there's always a race between the classification and that we pathologists develop and the clinicians who would like something that is good for the kind of treatment that is available at the moment. So this is a race that's been going on for many years, but I think it's a positive race. So at first, usually clinicians have problems with the new entities because of course they have no standardized treatment for the new entities, but we know as pathologists that really these are biological entities, so they are theoretically, it is theoretically possible to treat them differently. So I think, of course, it takes a lot of time before these new entities are accepted in the clinics, and of course the WHO classification is an effort to try and summarize this information into clinically useful entities that can be treated homogeneously. I think that one of the key points is that we need very good samples from the start because of course all the following information will depend on the starting sample. So biobanking is really an important issue. I think that morphology will stay there because it's very cost effective, so to say. I have the doubt about immunohistochemistry because molecular tests are becoming so cheap that immunohistochemistry might decrease in the future. On the other hand, we will be able probably to validate some new molecular tests will become routine in the next 5 years, I think.